A very warm welcome to the local and the global audiences of the 8th Global Forum on Nicotine. For this session on obstacles to tobacco harm reduction in low and middle income countries, LMICs. I am Dr. Sudhanshu Patwardhan, or SUD for short, Director of the Center for Health Research and Education and a medical doctor by training. Our center, CHRE, is focused on global cancer prevention, and one of the key areas of work for us is in tobacco harm reduction, where we are keen to bridge the public health policy and healthcare practice gap that's so widely prevalent globally.
Sud, it's a pleasure to share the stage with you. I'm a co-host. My name is Delon Human, also a specialist family physician, so two docs, hopefully busy with tobacco control and harm reduction for many years. I'm also the president of Health Diplomats, and I come from South Africa, which is an LMIC. And maybe just to qualify what an LMIC is, a lower middle income country, the World Bank defines this as countries where there's between $1,000 and $4,000 per capita earned per year. So it's the financially less resourced countries. And that's going to be the focus of our panel this afternoon. And we have fabulous panelists from LMICs to explain in detail what the obstacles are to THR. Thank you, Sud.
Thank you, Delon. It's a truly global panel, as Delon said, and I'm going to start introducing the panel one by one, and then we'll, of course, ask the panelists to give a very short, brief summary of what their thoughts are on this topic before we dive into questions from you lot here, from the online folks, and some questions we also have for them. So starting from east to west, so don't challenge my geography after the second one, of course. Starting from east to west, the first panelist is Dr. Sri Sucharita, Professor of Community Medicine at Tagore Medical College in India, but also Director of the Association for Harm Reduction Education and Research. It's a privilege to have you here, Sri. The second panelist.
Thank you.
The second panelist is Natalia Toropova, based in Ukraine. Now, she's a former WHO program coordinator in tobacco control and currently works at the Healthy Initiatives. Welcome, Natalia. The third panelist is Joseph Magero from Kenya, and he's a keen activist, a keen believer in tobacco harm reduction, and also the chairman of the Center for Safer Alternatives. And finally, last but not least, we have Tomas O'Gorman from Mexico, a lawyer by training, but also the co-founder of Pro-VPO, an advocacy group. So welcome to all the panelists. It's an honor to have you here with us online and with folks here in Liverpool. And let me start the conversation just to get us started. I'm hoping and assuming that a lot of you have actually watched the videos that three of the panelists have done, and there's a PowerPoint presentation by the fourth. And these videos are a good accompaniment to this conversation. But even if you have or haven't, it'll be good to start the conversation by asking each panelist to answer this one sharp question. So panelists, only 3 minutes max, if I may. And the question you have to answer is, what, according to you, can you list the obstacles to tobacco harm reduction in your country or your region? And if you had to rank them, what would be the top of those obstacles? If I may start with Shri, please.
Thank you, Dr. Sud. It's been a pleasure to be invited for this second year as a panelist, and I'm happy to share my experiences as a researcher and academic researcher and public health researcher in a country like India with a huge burden of tobacco. And to come back to your question and to utilize my time properly, the first and foremost challenge or barrier for tobacco harm reduction in our country is the lack of political will in articulating tobacco harm reduction in our national policies and realizing the potential of tobacco harm reduction in a country like India with almost 300 million tobacco users, either in smoking form and 200 million, especially in smokeless tobacco form. So that would be my topmost barrier or challenge, and followed by other challenges like medical professionals' lack of awareness about tobacco harm reduction and application of tobacco harm reduction as a main strategy in clinical practice. That is one of the other major barriers I have revealed myself as part of my research. And the third challenge is coming to the masses, the lack of awareness, the opportunities lost in educating our folks about the opportunities and options available to them. To be honest, there are not many options for them, but still, whatever options are there, like nicotine replacement therapies, their awareness levels are so meager. That is another challenge, according to me.
Thank you so much, Dr. Shri, and that's a great start. May I move to Natalia about challenges in your region and country as well? Natalia, you're not audible, at least here.
Can you hear me?
Now, thanks.
Yeah, sure. The region of the former Soviet Union is very complex and very diverse. And though most of the countries of the region adopted WHO Framework Convention on Tobacco Control 10-15 years ago, still the situation remains very grim in the region. For instance, only in the Russian Federation, 220,000 people die annually of tobacco-related diseases. And yet, the harm reduction strategy in the region is absolutely missing. If we have to name three reasons why, three obstacles, the biggest obstacles to the harm reduction strategy, I would say that the first one would be a lack of objective, solid information, evidence-based on risk reduction products. There is simply no data, no information available to policymakers, available to general public. Second would be a lack of trust. Our part of the world started to be invaded by tobacco industry later than other parts of the world. And several battles over the strong tobacco control legislations that took place in most of our countries were very recent, which is why the wounds, if I may say so, are still fresh. And most of the policymakers and decision makers and the public do not really tend to believe the information they have about RRPs in the region because it comes from tobacco industry and other derived sources. So that's a huge, huge obstacle that has to be tackled. And number three, that would be the theory of equalizing. Starting in 2016, several countries, Russia, Kazakhstan, Ukraine, Georgia, and several others started to equalize combustible cigarettes with risk reduction products. As a consequence, we see that snus has been banned in several countries, as well as nicotine pouches. Thank you.
That's a great summary of the challenges that you face in the region, and I'm hoping that as the panel progresses and we have more questions and discussions, we can find some common themes and some potential solutions as well, I hope. If I then move to Joseph in Kenya. Joseph, please.
Thank you. So I'll keep mine simple. The first challenge we have is affordability of safer nicotine products. The second challenge we have is inadequate policy support, which is driven by misinformation and also lack of research. There's simply no research on these products here on the continent. And the third challenge we're facing is a lack of support from WHO FCTC. The last one is, of course, tobacco-free kids and what they're doing here. Those are the only challenges we're facing.
Joseph, thank you so much, and I would like to come back to some of the points you raised, very, very topical, very relevant from a consumer point of view when you talk about affordability. But let's come back to that in a few minutes. Tomas, would you mind giving us your thoughts on the question and the perspective on that, please?
Well, thank you. Good morning from Mexico. I think that the first challenge is the position, the ideological position that our health authorities have. They have a complete adhesion or adherence to the FCTC and to the idea of the abstinence-only model. This position is obviously reinforced by the influence of of international NGOs like Bloomberg Philanthropists, the Union, Tobacco for Kids, etc. And another challenge which I think we must overcome is the lack of information. I mean, in two aspects. In one side, all the available information, scientific studies, papers, is in English, and in the other side, there is no research in Mexico regarding safer alternatives. So there is a lot of misinformation and ignorance, not only from the authorities, but in the legislator side also.
That's a very good summary, and of course, for those who have seen all the video presentations, including Tomas's, you will notice that a common theme that already emerging is the lack of adequate support in cessation in most of the countries we are talking about, and that's an important one, given all the discussion about the MPOWER package that is there to help cessation efforts, or the O part of it is for supporting cessation. You can see that that's very glaringly absent in terms of actual delivery, and that kind of feeds into a lot of these things. I'm just going to look at you, Delon, in terms of, are there any interesting questions online?
Sid, well, you might have heard that both Thomas and Joseph spoke about the deficit in trust. Natalia said that as well. And then specifically the attacks by Bloomberg-funded advocacy groups. So the question to our panelists are, in your respective countries, have you observed any effects, good or bad, on local populations based on the attacks and the presence of Bloomberg-funded advocacy groups? And both Joseph and Thomas mentioned the campaign for tobacco-free kids. Your views, please, panelists.
So if I go first, I say that we had nicotine pouches introduced in the country, I think 2 years ago, but there was a lot of uproar from our counterparts in tobacco control with claims that these products were making children basically were destroying their brains, and as a result, the product got suspended. And finally, when the product was allowed back into the market, the taxes on it just made the product virtually unaffordable to those who were using the product. So those are some of the effects that I've seen personally happen in my country.
Thank you, Joseph. And Thomas, in your country, what has been the strategy of these groups funded by Bloomberg to attack tobacco harm reduction?
Well, first, e-cigarettes have been banned in Mexico for more than 10 years. So during all these 10 years, we have been, as population, receiving a lot of misinformation regarding safer alternatives. So the principal effect is that people don't believe that e-cigarettes are a much safer alternative for nicotine consumption. That's the main effect, and that's an obstacle that we should overcome, because this misinformation also affects legislators and other authorities, and maybe even doctors. The other effect is that you can see a constant influence of these funded NGOs with authorities and legislators actually like almost forming a team and excluding any other participants or any other stakeholders from the discussion and from the debate about how to reduce the harms from smoking. And as you said a few minutes ago, they are only considering prevention as a valid strategy, because yes, they talk about cessation, but I believe that there is not enough efforts to help smokers quitting. So I believe they are just abandoning smokers, and they are worrying about only having people abstain from starting smoking.
That's, if I may just use the chance to also not leave out the other panelists, and especially Shri, I'm going to point this one to you and extend the question to you, because I know that you have in the past written and talked about what's called philanthropic colonialism. Is there an example of that in India as well, and would you mind elaborating on that?
Yeah, thank you for directing this question to me, though I was trying to stay and hear the views of the other panel members. Yeah, we were a little bit taken aback, as it was almost like a PTSD kind of experience for Indians to have this being experienced again. The philanthropic directions coming again from other shores and being infused into our health policies, especially for a country like India to receive huge funds, and especially tobacco. And there are certain health policy targets specifically designed for tobacco to be achieved by the end of 2015. The national health goal was to reduce the prevalence of tobacco use by 15% and another 30% by 2030, so that the non-communicable disease death targets have to be reduced, cancer death targets have to be reduced. With all that backdrop, suddenly when there is an opportunity to, adopt certain new trends and new evidence, there was a sudden change in the policy environment with a ban of so-called products which are actually being regulated in the outer world. And this ban is not just to the products, but the ban extending to the academic corridors. And the research was banned. There was no discussion about it. We were not even allowed to submit research proposals, which is unheard of. That was never in India, that a research about a product or a medical topic was not allowed in a medical institution by a medical doctor, which was in my 30 years as a medical professional, I never heard of from my medical school days. So when we went and looked into it, what is driving this kind of aggressive stand by the government of India, we looked and we were wondering how it happened. Then certain sources of information was telling us like there is some kind of a top-down approach, and certain philanthropic funding is being supported in this kind of policy direction. So it helped us to understand the dynamics, and certain trends in other countries also helped us how this philanthropy is being extended to low and middle income countries. And suddenly the union came out with this position statement paper saying that why bans are good in LMIC. That revealed, it made it so transparent where these interests are coming and how they are colliding, and what are the outcomes for LMIC with 80% burden of tobacco being concentrated in this population. So without much elaboration, because every one of us in these platforms know what was the damage later, and it is still happening. And with the latest World No Tobacco Day awards, tokenisms, these are nothing but re-emphasizing that particular stand of philanthropic encouragement being given to these countries because we are delivering what they wanted. Right?
Absolutely. Dr. Shri, that's a great example of what's happening on the ground. And I'm glad you also brought up the point which I was hoping to have a conversation about, which is often forgotten in the broader tobacco harm reduction conversation. And that is 80% of the consumers of risky tobacco products live in LMICs. And we should not forget that there's a need to accelerate the delivery of tobacco cessation solutions to those who have not yet, even as one of you said, have awareness of the challenges, the products that could potentially help them live healthier and longer lives. And so there's a whole gap that needs to be plugged there. And so the interesting part of the conversation is about, as you mentioned, Sri, the PTSD almost arising from some of these traumatic things. There was an issue about trust and the trauma that Natalia mentioned earlier. Can I switch gears, please? And Delon, with your permission, I would like to see that of the 4 regions and countries we are talking about, 3 at least, I can say, have also a strong presence of local oral smokeless tobacco products, all known to be quite toxic. It'll be good to perhaps just get the panel's view on what harm reduction means in the context of these products, and not necessarily harm reduction as we often tend to think in the Western world as smoking harm reduction. Would that be a good thing to position?
Yes, Sut. And then I've grouped some questions that we can address after that.
And I don't want to forget the audience here. You are equally special to us. We will come to you. I want to just see somebody sort of signal, and we'll ask you to come to the mic. So if I may ask this specific question first to Natalia regarding what in her presentation she talks about NASWE, and then we move from there to perhaps Joseph and then to Shri. Natalia, please.
Yes, I'll talk about NASVI, and that's the phenomenon very typical for the Asian parts of the former Soviet Union region. If we take Uzbekistan, that's a great country, and there is a huge problem of NASVI. This is an amateur tobacco for oral use, and the point is that it's completely not regulated. If we compare the smoking prevalence and NASVI prevalence in the region, we can see that the prevalence of NASVI is much higher than the actually the one of conventional cigarettes. It's almost 25% of men of Uzbekistan are using NASVI. The point is, and the problem is right now, that in the region, this product is not regulated at all, and there are calls either to ban it completely or just allow it. So there is no attempt to regulate it, to find a golden mean. Also, at the same time, NASVI is now participating in the black market, and this is just only the beginning. It started in Uzbekistan, but we can also see this phenomenon in Kyrgyzstan and in Kazakhstan. And at the same time, we can see that policymakers of those respective countries do not pay enough of attention to this very issue, which is going to be very dramatic eventually.
So a quick online question to you, Natalia, concerning the Russian Federation.
In the Russian Federation, no, NASVI is not an issue for the Russian Federation. It's an issue, as I said, only for Asian part of the region. However, it may touch the Russian Federation in the sense that there is a huge percentage of Uzbekistan men and women working in the Russian Federation as migrants. So in this sense, this does become the Russian Federation as well.
Understood, Natalia. There was just a question online about the use of nicotine pouches and snus in Russia, and where it is prohibited. Is this correct? And then the question is there a gray market, is there a black market of snus being sold in the Russian Federation?
There is no black market of snus in the Russian Federation. Yes, snus is prohibited in the Russian Federation now, as well as nicotine pouches. But at the time, snus did not become popular enough in the Russian Federation to become an issue for the black market.
Okay, thank you.
If I can then proceed to the other two panelists who can potentially talk about smokeless tobacco use in their countries and regions, please. Shri, you want to take on first, and then Joseph, in short.
Yeah, smokeless tobacco definitely is a huge problem in India. As I discussed earlier, almost 200+ million users, especially from low-income groups, are using smokeless tobacco, and also it is widely used by women, migrant populations, and also by other population groups such as sexual minorities and people who are marginalized for a variety of reasons. The only reason for such wider use of smokeless tobacco is because it is widely available in different varieties and different brands, and it is widely unregulated market, and it is affordable to a lot of people. And in northeastern states of India, it is also very commonly used because of socio-cultural sanction given to discreet use by women and young girls. So these are the socio-cultural determinants: cultural sanction, discretion of use, easy accessibility, affordability, wide range of products, poor regulation by the government. These are the factors which lead to higher use compared to cigarettes. And also taxation is one issue. Time and again, in the name of taxation as a strategy to reduce the supply side of the thing, and also to reduce the demand of the users, to reduce access. Taxes are increased on smoking products of tobacco, and it is not done in the same way for smokeless tobacco products in India. In our experience, people do have access to this. These are the factors which contribute to high burden of smokeless tobacco use in India.
Thank you so much. That's a very helpful sort of almost overview of the entire smokeless space, and also some of the crucial issues in current regulations even that are not evenly applied to smoked versus smokeless tobacco. Even within smoked, as we know, perhaps more applied to factory manufactured cigarettes versus BDs, but that's a separate conversation now. I want to hear your thoughts, Joseph, on not just Kenya but across Africa, the use and prevalence of oral tobacco use, please. Joseph, we're having some problem hearing you. Sorry, would you mind seeing if there is some, just can you try again, please?
Let me switch to Thomas.
Yeah. Joseph, look, I think there may be some technical problem. Why don't we come back to you with this question, see what may be wrong with your system, and we'll come back to you for this for sure. While we are sort of...
Yes, so two key questions come out from the online questions, and I do invite all of you to be here on site to ask questions as well. But the one key question is, why has tobacco use increased so significantly in Africa by about 52% between 1980 and 2016? What are the underlying or contributing factors to these? Is it a greater disposable income? Now, the same is true for the other regions of our panelists. That's key question number one.
Yeah.
But then I'd like to ask the panelists to think of another question online, which said, in your view, what would you see as the most appropriate reduced risk product instead of tobacco in your region? It would be good to hear our panelists' view on that.
Absolutely. So shall we start with Thomas in this case on what do you think? I think you mentioned in your presentation, Thomas, there's 16.1 million smokers in Mexico. And for sure, if they have not tried to quit or they've tried but they have failed, they must need some alternatives. And that's what we're talking about in harm reduction. What's your views, please?
Well, yes, we have about 16 million smokers, and what I believe is interesting is considering that lots of people want to quit smoking, and according to the ENCO, as I placed in the presentation, most of them, 85%, the ones that tried to quit smoking in the time of that study, they just tried to do it cold turkey. So I believe that an important aspect to be considered is that people they don't consider themselves like patients or that they are suffering from some disease. So they just don't want to go to doctors. They don't want to use drug therapy in order to quit smoking. So authorities have two problems. They have to convince people to quit smoking, but they have also to convince them to go to a cessation clinic, and that is very difficult. I think it's much easier just to offer them alternatives, because the first goal that we don't have to forget is that the most important thing about tobacco control is to reduce harm, and it's not abstinence, it's the harm. So I believe this is very important, because my guess is people don't want to use drugs, and they don't want to use traditional cessation methods. If you see the ENCO, that only 3.5% of the people that tried to quit smoking used pharmacotherapy. So I think they should devise alternatives, or they should use interventions designed for the people needs, and not to impose their own views on how people should quit smoking.
Thomas, that's a very important point you're making about consumer choice in terms of making decisions about their own life and health. Of course, it needs to be supported by healthcare professionals, the regulators, the governments, and the broader policy framework. I want to come back to one more key stakeholder, but I want to first hear Natalia and Shri on this question. So Natalia, please.
I would say that for the region of the former Soviet Union, that would be an electronic cigarettes, because if out of all risk reduction product, we had to identify, let's say, one that has more or less trust and that has potential in the region, I would say that people tend to trust more, as well as policymakers, to electronic cigarettes. However, and that's the paradox, at that very moment, it's the e-cigarettes that actually stagnate in our region, while the heated tobacco products are more on the rise. So that's why there is this contradiction, and there is this paradox that has to be handled somehow.
Can I, and you are our esteemed panelist, but I would like to challenge you a bit, although I promised I'll be nice. So the challenge, Natalia, is this, that of course, I don't think anyone expects you to have to choose between or just have one product that you think should be the solution for your market and your country and region. If you had a choice of more than one, what would you say then?
Definitely the HTPs, definitely, but they are on the rise anyway. The point is that right now we are trying to involve doctors, because that's the voice of doctors that has to be counted, and that is very decisive. And if you talk to doctors in Russia, in Ukraine, in many parts of the FSU region, the first thing they talked about as an error piece, that would be an electronic cigarette. And I would suggest that this is something we all should care about, because this has potential. And if the doctors are willing to take up this very tool and actually tie it to cessation the way it should be, then this is something we should encourage and support.
Sure, Natalia. I would like to still come back with one more question, but I'll come back in a few minutes, if you don't mind. Shri, a very quick answer, because I think we have got Joseph back now.
Yeah. So if I understood the question correctly, as an academician, we always go with this approach called cafeteria choice, educate people, provide choices, make them choose an informed choice, what is good for them according to their lived experiences. So provide them, though it may not be applicable in low and middle income countries, even then I would advocate provide them options, provide them education, information, so that they will make an informed choice. So if the landscape of tobacco harm reduction in a developed world is offering electronic cigarettes, Swedish skills, heated tobacco products, and what not, it should be equally available for low and middle income country population also. So my principle is harm reduction for all.
That's a great way to end that answer. Thank you so much. Joseph, we believe we have you online, so let's give it a shot.
Yeah, so I didn't get the question the first time. So
of course. The question was, in your country, if you had a choice of products that you would find as a potential solution for, as harm reduction solutions, what would they be?
Personally, I go for oral nicotine products. For reasons being, number one, those products are legal in every country here on the continent. Secondly, affordability. I think compared to e-cigarettes, those products are readily available, and most smokers understand smokeless tobacco, so it's easy for them to understand how to use snus, for example, or oral nicotine products. We had a survey done last month, and on oral nicotine products, 82% of people who are using the products were former smokers, and that was incredible to note. That means that they're readily acceptable, and if they're made available, I think it would cause the most shift from conventional cigarettes.
Sudha, I'm very interested to hear what his recommendation is for the most effective reduced risk product in Mexico. So we've heard from Natalia, electronic cigarettes probably in the CIS, Ukraine. And then Joseph has now spoken about oral nicotine as probably the most appropriate for his region. What about Mexico?
Well, in Mexico, oral products are virtually non-existent, so we are left with two options: vaping and heat-not-burn products. Vaping has a longer history of being present in Mexico. We have around 1.3 million vapers, according to official information. And heat-not-burn was recently introduced in Mexico, and I guess it was being accepted, but since last year, also the government banned the importation of the devices. So I think the two alternatives that should be implemented in Mexico are vaping and maybe heat-not-burn tobacco products. But today they are not legal to be sold or commercialized.
Thank you, Thomas. Well, it's clear that from the responses from our panelists that accessibility, affordability, and acceptance by the consumer of the product are really key to help with this journey of tobacco harm reduction. We also have some questions online about quitting, but I would suggest that we give Jonathan Fell the chance first.
Absolutely. John, would you like to introduce yourself and just get on with the question?
Hi there, it's John Fell from Ash Park. Thank you, panellists, for the videos and your comments. It seems like part of the issue in LMICs is a policy one, a government attitude, and then there's the issue of what the companies selling reduced harm products themselves, what they can do. If you could pick one or two things that the companies selling these products aren't doing and should do, or should do better in your countries and regions, what would those things be?
If we have a, why don't we go around the panel if everyone wants to answer it, but I guess I want to look at Joseph now, saying because there was a recent launch in your country, and there's a lot of interesting things that happened around it. Would you want to talk about it, and what are the learnings from that, Joseph?
Well, listen, I think what they shouldn't have done is perhaps not put them in colorful vending machines and put posters everywhere.
Joseph, sorry to interrupt you. We want to hear this, but I think it's key for the rest of the global and local audience to know what are we talking about here, what products, and don't necessarily need to name companies.
We're talking,
Yep.
okay, am I supposed to name companies? I don't think.
No, I don't think you're expected. It's just about the product category and the learnings around it.
Yeah, so I'm talking about oral nicotine products, right? So the uptake here was vast, and I think what they shouldn't have done perhaps is not put them in flashy colors and vending machines. I don't think that didn't work well.
There's also, if I could, Sud, there's a question here about, and this signifies the difference of products in the different regions. And this question is vaping the real solution for tobacco harm reduction in India? And does vaping have a role in India?
Can we merge that with the question John asked? Because I would like the panel to have a go at the question he's asking, because I was almost getting to the point when saying there is one stakeholder missing in this conversation, and that's the industry.
Exactly.
And that's a very great way to kind of get the panelists to kind of really talk about what role can the industry play in their respective countries and regions. So maybe, I don't know, Shri, you want to start, and then Natalia, and then Tomas, please?
Yeah. If I would respond by taking that question whether vaping has a role in India, definitely, because there are 100 million smokers in India, so vaping can have a space in India if it is fulfilling the other ticking items in the checklist called affordability, pricing issues, and making it regulated for adults, not for teenagers and adolescents as a tool of fashion or cool aid or something like that. We advocate electronic cigarettes as a tobacco harm reduction tool for adult smokers who are intending to reduce the harm of tobacco. Right? That made clear. Yes, we have been part of one pilot study where we are aware that when vaping devices are made accessible to BD smokers from low income group, as a pilot study I'm repeating, they were very keen to use it, and they were successful in transitioning from BD, which is very harmful combustible tobacco product, other than cigarette in India, which is widely used by low-income groups, and their experiences of using e-cigarette or a vaping product were almost equivalent to any high-income group individual using a vape product. So my conclusion from these two statements is, yes, with 100 million smokers in India, a vape device, when it is made as a tobacco harm reduction aid and promoted as such among adult smokers and adult tobacco users, does have a role which we can explore, definitely.
Sure.
And coming to the,
please, sorry,
is there another question?
Yes, please. Thanks.
If there is another question which was asked in continuation to that, I would like to respond.
Please answer. Thanks.
But I don't remember the question.
That's mighty honest of you. It was about what's the role of industry in this whole tobacco harm reduction conversation we are having in India, particularly in this context for you.
Yes, thank you so much. I apologize for that blip in my memory. And coming back to this entrepreneurship in tobacco harm reduction, all of you know that India is home to a lot of entrepreneurs, and if tobacco harm reduction is explored in that spirit, I definitely think there is a potential to develop more tobacco harm reduction products. And if that is where I mentioned political will, political articulation of tobacco harm reduction as a potential avenue to be promoted as an entrepreneurial avenue by the government will open up this market, and it will definitely help entrepreneurs to come forward and think of manufacturing Indian version of Swedish snus, because we have 200 million smokeless tobacco users, and even electronic cigarettes for 100 million tobacco combustible users. For Indian version or Indianized market can definitely be sought by entrepreneurs.
Yeah, that's a great answer. Thank you so much for that. And Natalia, do you want to respond to this? And maybe Tomas, and then, but let's try and wrap this in the next minute or two, and then we have a bunch of other questions.
I think that if we talk about the role of the industry in the FSU region, it can actually be quite crucial in promoting harm reduction products. And one of the things the industry can actually do, that would be not to create obstacles in promoting tobacco tax increase in terms of conventional cigarettes. Because once the tobacco tax increase takes place for conventional cigarettes, that gives a great chance actually to harm reduction products.
Thank you so much. That's a great answer. Tomas? Tomas, would you mind answering about the role of industry in your country? His audio is gone, sorry.
So maybe I can just link this question, Jonathan's question, to the two keynotes. Both Derek and Cliff Douglas spoke about the need for investment in R&D, either product-based by the manufacturers or R&D by scientists independent of industry. We want to know what the panelists think, what they think of the role of R&D and investment in R&D in these reduced risks in their region.
Shall we start with Joseph in this then?
Sorry, repeat the question for me, please.
The role of investment in R&D in reduced risk products, Joseph. Is there a place for that in Kenya and Africa, for instance?
Yes, there is. Look, I don't have any objection to the industry, tobacco industry investing in these products. I think the fact that they're trying is a win for public health, because they're not obligated by anyone to try. So I think it's a good thing that they should look into.
Thank you, Joseph. Natalia?
That's definitely something that the region is missing, and that is something we would really welcome in the FSU region, if this is possible, and that's something we would like to promote. But unfortunately, at this point, we do not have this independent survey and this independent data.
Thank you for that answer, Natalia. In fact, before we move to the next panelist for an answer, well, Tomas, I know that in your presentation, you talked about a lack of annual surveys, for example, no survey and no long-term data in terms of tobacco consumption. And of course, we know in the UK and in many of the developed countries, that's pretty standard, and that allows us to really track in real time tobacco consumption and the unintended consequences of harm reduction products. For example, in the UK, great surveys from 2011 have allowed us to really be confident that these products are only being used by intended consumers, which is adult smokers, and allows us to have that right balance of regulatory strategy. Tomas, with that in mind, do you have any answer for this point? I believe you're back online now. Or maybe not. My apologies. I'm sorry, I misunderstood. Look, we'll come back to you, Tomas, as we just move on. Shri, do you want to have a quick answer on the research and development gaps? And not just, if I may just add to your question, Delon, but not just on the product development, but also in terms of the clinical trials and stuff that needs to be done. And I remember there was a paper in our special issue of on this topic, the lack of harm reduction related research in the global south, as it's called. Shri?
Yeah. Yeah, I remember the paper you are referring, the global north and global south gaps. Definitely, there is a scope of improving and bridging this gap between these two global north and south when it comes to tobacco harm reduction and especially clinical trial kind of research. But as I mentioned in my video presentation for the conference, I don't see how this is going to happen when it comes to really translating our intentions and our discussions in these forums into real world research materialization, because we talk, we write mails, we approach people, but it is not translating into real world funds and grants and clinical trials and actually conducting trials with international multi-center teams or studies. That is my first concern. And coming to the product designing, research, R&D investments from industry, first thing I would like to submit here is, unless from top down, the policymakers, the research permitting institutions like ICMR and ethics bodies are sensitized about the importance of funding such research, they are not giving grants for such research. And second thing, if someone else is funding from industry or independent industry CSR granted bodies like foundations or otherwise also, they are looking at this research as something unethical. And as we already know, they are looking at the researchers with some kind of conflict of interest and some kind of personally motivated researchers. So this kind of entire shady twist or tinge given to this issue has to be gradually eroded with a lot of concerted efforts. And second thing, only this kind of research will actually elevate the potential of bringing new products into a country with a huge burden like India. And even if one or two potential manufacturers are actually bringing out products, they are exporting to other countries. Those products are not having any value or merit for the use of our tobacco consumers in a country like India. So all these factors have to be figured in when we are talking about LMIC's potential in manufacturing and whether those products can actually benefit our users or not.
Sri, thank you so much for that answer, and it's really important for us to understand the challenges in terms of not just availability of funds and donors and so on, but also what happens when institutions actually get the funds and what is it perceived as. But there's a lot of work to be done, and I'm glad that people like us are all working in that space. Of course, we need many more people to join in this effort. There are a couple of questions that Delon wants to.
There are two questions that we should address. Number one, we should remember that quitting is the first pillar of tobacco harm reduction. And the one question we have online is, what psychological barriers are there for quitting smoking in your region? And I was particularly interested in Natalia. In the Ukraine, Russia, and the CIS countries, what would you see as the most important barrier to quitting smoking?
And this is something I'm very, very concerned about, because the cessation in our region is absolutely zero. It's absolutely non-existent. There is no attention to smokers' problem, and that's why there is no attention to cessation problem. As we know, Bloomberg Initiative never supported cessation, which is why this issue gets completely ignored and neglected in the FSC region. For instance, in Ukraine, there was a smoking quit line service, which existed for a little bit over a year, and it was funded by the WHO. When the funding disappeared, so did the quit line. In Russia, officially there is a quitting cessation line, but it actually not on smoking, because right now it embraces all kinds of issues, mainly the COVID-related issues, but not smoking. So smokers, once again, are left alone. And it's a catch-22, and there is absolutely no cessation mechanism, and no one really cares. So if we are actually talking, relating to the previous question, if we are talking about investments in surveys, it's a vicious circle. No attention to smokers, no attention to cessation, and no attention to the survey, because it's all related.
So it seems to be the hot topic, especially during the keynotes and now, is the attacks on tobacco harm reduction advocates. And there's another question here on the Bloomberg-funded Stop campaign. I think we've all heard about the $20 million donation to the University of Bath as part of the STOP campaign. And the question is it not time to have an alternative to the Bath Bloomberg-funded STOP campaign? Maybe a campaign with a website listing every contribution to harassment. And I remind you to our panelists' remarks. Sri spoke about the post-traumatic stress disorder. We had Thomas also mentioning, and Joseph mentioning, that the attacks on tobacco harm reduction advocates. So is it not time for an alternative, a pushback, a website listing the harassment? To any of the panelists.
Can I answer this question, please? Because that's a very acute issue for the FSU region. The BI track is very, very obvious and has very negative impacts in our countries in terms of harm reduction products. And it's basically about massive lies about harm reduction products. As a good example, I'd like to provide you an evidence from Ukraine, the capital of Ukraine, Kyiv. For several months, all over the capital of the country, there were posters and billboards promoted by the Vital Strategies about electronic cigarette equal to the conventional cigarettes, and electronic cigarettes giving you a black lung effect. And this is something that gets promoted all over the country. This is something that gets delivered to policymakers by the BI-funded groups. That's just a very vivid example of the lies and manipulation that we are facing in the region every single day.
A quick answer by the rest of the panelists. We have a couple of other questions, so and we have about 8 minutes left. So really quick answer, please.
Okay. So if I can answer, I think it would be important. I didn't actually know I was on the Bath list until early last year. When I was talking to the Minister of Health. So I think we should have our own list, because personally, I never left tobacco control. Tobacco control kicked me out because of thinking out the box. So if we could have our own list, I think it would really be beneficial.
That's a great answer, Joseph. Thank you so much. Shri, you want to add anything to this?
I do support all the views by other panelists, and the proposal made that we can also list up all the issues we face related to this particular issue, and we can also start compiling all these issues at one place so that we can keep comparing what is the score.
That's a very, very helpful answer and set of answers from all of you panelists. And I'm getting a message that Thomas is unfortunately not able to connect audio, but we hope that we can get him back just before the end of the session, which is in 5 minutes. We have him back, I'm told now. So Thomas,
yes.
You have missed some of the action, but I think we're kind of coming to a conclusion here. Why don't we start with you in terms of literally one line? If we started with, what is the biggest obstacle to tobacco harm reduction in your country or region? If you don't mind being the first one to answer, if you had one first thing that you get out of your office and home now and go and do work in tobacco harm reduction, what would be that first thing you would do as a priority? In short.
I think the priority is changing the position of the government of holding the abstinence only model, and if they open their minds to the enormous possibilities that harm reduction offers to smokers, that would be awesome. If they are willing to listen to us consumers, are willing to listen to scientists that are supporting with their papers that what is science is showing, there would be an enormous achievement, because smokers could have access to better alternatives. So the most important thing is, I believe, to change the ideological stance of our authorities.
Thank you so much, Thomas. That's a great way to summarize the need for scientific evidence-based policy making and a desire to make some change happen. If I go to Natalia next, Joseph, and then Shri. Natalia?
Yeah, I would actually like to echo Thomas in this, and also mention that the first thing I would do is focus on education and awareness building campaign on harm reduction products, and also on building a team of right people who would actually care and be dedicated and committed to bringing the truth about and to changing it and actually care about smokers and make the harm reduction strategy the key of tobacco control at this point.
Thank you so much, Natalia. That's such an important thing. And again, as Delon reminded us, tobacco harm reduction is the principle that underlies the idea of helping people quit their risky tobacco habit, be it smoking or in the case of many of your regions and countries, risky oral tobacco products. Joseph, would you want to have one final line or two on your views on what's your next action going to be? Because we believe that you are one of the champions in Africa leading this work.
Well, I think it's just to keep focusing on the misinformation and educating government stakeholders on nicotine and also research. I believe that research is what is going to change policy here, and that's what we're lacking at the moment.
Powerful statement, and I think this misinformation that is prevalent globally, and I'm going to use that to link to one thing that I was hoping to also have Shri mention in one of the research we did last year among healthcare professionals in India, and we've done this in the UK previously, and of course we have seen from the US last year these misconceptions about the safety profile of nicotine in tobacco products is quite shocking, and nearly half of the professionals think that it causes cancer when it doesn't. And how do you expect tobacco harm reduction, which is kind of underpinned by the fact that you're giving safer nicotine alternatives, how do you expect tobacco harm reduction to be accepted, embraced, and then practiced by these professionals? So as a doctor, Shri, I would point this to you saying, when you go out as a physician or as a practitioner and as a professor, what's your first thing going to be in terms of tobacco harm reduction?
Yeah. I would like to summarize here that as a physician and also as a public health professional and researcher, my foremost role is to play the public intellectual role in spreading the information on tobacco harm reduction, especially in India, the literacy about tobacco harm reduction. I need to take my job seriously, and I'm doing that a little bit, but I want to be more serious about it hereafter after seeing the kind of policies being rolled out. And the second most important thing is like harm reduction for all. I'm repeating it again. That should be the my message wherever I go. I would like to spread that philosophy.
Thank you so much. Very honest answers by all the panelists, and let me assure you that your work and your commitment is appreciated by all here and globally, and by the 1.3 billion people out there using risky forms of tobacco. They may not know that, but this is happening for them. Delon, may I conclude the session, or you have any last?
I think the two points that have also come through is the need for good product standards to address the safety issues in the regions that we are addressing in this panel.
Absolutely.
And then we've also discussed the need to prevent youth of using this. And we've mentioned that 2 or 3 of our panelists, and that needs to be emphasized here at the end.
Absolutely. Look,
thank you for a fabulous contribution by all of our LMIC advocates.
No, I think that's great, and I'm glad you brought these 2 points up, because this is important. We don't want to have a new epidemic while we're trying to address a current epidemic, yes. And that should not ever be forgotten. I think to summarize, we had a great panel. Delon, great contribution, and thanks for being a teammate on this one. Great support from the audiences here and globally. If I may just make you do some more work, not now, you can have your lunch now here, is to go online and check out the GFN'5s, and we have picked 5 GFN'5s which are more pertinent to the LMIC theme. One is by Sahan Lungo from Malawi, talking about how Malawi is getting into diversification beyond tobacco, but let's not forget tobacco harm reduction for current tobacco users there. The other one is by Daud Malik from Pakistan at ARI, talking about the high tobacco use prevalence and the same theme, which is absence of tobacco cessation support and so on, but very interesting video to watch as well. The third is by Dr. Deepthi Bandaru from our team, in fact, in the northeast of India, and oral cancer prevalence is very high there because of high oral tobacco use, and what are we doing to address that? And so it's again throwing a light on what needs to be done on the ground. The fourth one would be a very different one, not from an LMIC, but a person who is passionate about what could potentially be done in LMIC, which is Mr. Bengt Weiberg in Sweden, and proposing products like nicotine pouches, again, back to the quality product standard stuff and making sure they're not accessible to youth who they're not intended for. And one final presentation I would encourage is that by INCO, again, which was, I believe, played at the beginning of this session, but would be worth going back and checking in GFN'5. I really appreciate your patience till now and great questions from all around the world. And it was an honor to co-host this session with Dr. Delon. Thank you so much all.